Welcome to the BioBalance Healthcast, episode 678. Dr. Maupin's lecture to other doctors. Why women need testosterone. Part 2.
BioBalance Healthcast features conversations about anti-aging medicine. Your host is Dr. Kathy Maupin, Medical Director of BioBalance Health and a leading expert in treating symptoms of aging. Dr. Maupin is the author of The Secret Female Hormone, the seminal work about testosterone replacement therapy for women, and Got Testosterone, the award-winning book for men that helps men choose the most effective and safe form of testosterone replacement. These books are available on Amazon or from Dr. Maupin's office at BioBalance Health in St. Louis and in Kansas City. Dr. Maupin's office is currently accepting new patients.
So women need testosterone to be productive and healthy after 40. They need to be emotionally balanced. I'm sure all of you men would really appreciate that. And we need to be sexually active throughout our lives. So why is it a secret? Why is everybody not talking about this? The current culture believes that older men marry younger women. But it's not really accepted still that older women marry younger men. So women are not sexual beings after a certain point. And that's just a shame. So part of this is that our culture doesn't want to think about this. I'm not sure that that's true in Europe, but it is here. So nobody wants to talk about sex after 40 in women. So that's one of the reasons we don't hear about testosterone. Another one is it costs money. Giving testosterone to women is yet another thing the government has to pay for. So this is one of those things that we're just going to cut women out of this deal like they did in England. They used to allow women in England to have both estrogen and testosterone pellets. And they then 10 years ago said, National Health Insurance or National Health Service has decided that it's for the worried well. Women don't really need this. We're taking it away. So all the doctors that were expert at this quit doing it. And I thought maybe some of them still remain, but we went to England a month ago and didn't find too many doctors in England still doing it. And that's a big shame because they really were good at that. Dr. Studd is from England. He did lots of the early research. He's still doing it, but I'm not sure where he gets his pellets because they've made it very difficult. So I'm going to go back one. So last is gender bias. We've been reading a lot about that. Gender bias in research, gender bias in money spent on drugs and medical problems. So we're battling that. And in the middle of that, we have something that we need research on, and it's the same hormone that men have research on, but we're not getting the dollars for it. And I'm not sure, I don't know enough about governmental spending on research to understand why that's true. Okay, so the roadblocks to people knowing this, you need to know this if you're talking to patients and they say, why haven't I heard this? Well, it's an orphan medical specialty. Most of the research is done in endocrinology journals. Endocrinology rarely takes care of sex hormones, but they've got tons of stuff in those journals about pregnancy and all kinds of estrogen and testosterone issues for both men and women, but endocrinologists aren't using it. So that information never crosses over to ACOG or urology. So it's an orphan medical specialty. All that research and no one to read it. It doesn't have a name, so I named it testosterone deficiency syndrome because it's not andropause, that's men's. So we need our own name. And it's not perimenopause because it has nothing to do with estrogen, has nothing to do with the loss of estrogen. It comes way before that. It's the first thing to go. And symptoms in research are researched with testosterone and one symptom, never the group of symptoms. I realize that that's much more difficult to do in research, but they aren't calling it a syndrome. All these symptoms that go along with it are there, and they should look at all of them together. Okay, so the syndrome, we've talked about some of the aspects of why we don't know about it or why our patients don't know about it as well. So these are the symptoms, and this is on the web, and so you can download it. I'm not going to go through all of this, but this is similar to what we give our patients for their questionnaire. And then what are the treatments that we give patients that decrease their testosterone? All of these are used very frequently for good reason, but they decrease testosterone. So you need to be aware of that because sometimes patients don't have such a low testosterone. They just need to be taken off one of these drugs and given something like fish oil or red rice yeast or something instead of a statin, something that's not going to impair their testosterone. Testosterone replacement is efficient. It is one hormone we used to make, and very few side effects. I mean, hair on your face compared to all this other stuff. I mean, a little hair you can have it waxed off. But we have ways to prevent that as well. That's not commensurate with having all of these illnesses that we could just take one hormone for, and we'd feel great and have sex. So it's a very efficient answer, which most people in government are looking for, but no one's looking at this. So testosterone loss is the first step in aging. It's the first hormone to go, usually in most women. So this is just kind of a visual. Aging starts with testosterone loss, and then in women, that triggers growth hormone decrease. Then usually progesterone independently decreases, and then the last one, number 3, is estradiol. So, or you can look at like these stair steps. I was trying to learn to do this stuff on the computer, so bear with me. It doesn't look that great. Okay, so symptoms of the aging cascade. We've talked about TDS. Growth hormone deficiency is a loss of lean body mass and more fat, loss of muscle mass, poor healing. And then progesterone, of course, is PMS, dysfunctional uterine bleeding, and irritability. Irritability is big. That sometimes is low testosterone and sometimes progesterone. So if the testosterone doesn't kick it, we add progesterone even if there's no uterus. A bioidentical progesterone, and usually if they're cycling, just day 14 through 28. Estradiol deficiency, that's the last step, and then it's kind of over in terms of changing. That causes hot flashes, dry vagina, and dyspareunia. And in med school, all the guys, I was in med school when there were 7 women, and there were 112 doctors, so 7 of us survived that. And they used to say things like, dyspareunia is better than no pareunia at all. Well, I can guarantee you that it's not. I mean, no pareunia at all is much better than that. It's like sandpaper. So, long-term effects of TDS, the diseases of aging. If you don't replace testosterone, then the things that happen associated with aging are going to happen faster and more severely. So the structural diseases that occur, osteoporosis, sarcopenia, if anybody wasn't here earlier, that's loss of muscle mass, and that's what really makes people unable to live alone. They can't get around. They don't have any muscle. They're all bent over. That's not their bones. That's their muscles. And testosterone maintains muscle mass. Frailty is the outcome of sarcopenia, where people are like breakable. They're like little glass dolls. And you have to be very careful because they look like they're going to break, and they can't take care of themselves because they're afraid. They step off a curb, they might break something. And then, of course, obesity. Testosterone is one of the functions of testosterone is to make you insulin sensitive. So it actually combats obesity. Inflammatory diseases, we talked about this a little bit. Autoimmune disorders, atherosclerotic heart disease, Alzheimer's. Testosterone is an anti-inflammatory. It kind of does it all. So it's just as good in women as it is in men. It does the same stuff. So why don't we get it? It's kind of like, I want it too. I mean, everybody, it's okay for guys that, in my state, they pay for it for men, even for bioidentical pellets in general, but they're not going to pay for women. Illness due to long-term depletion, and that goes through depression, neurotransmitter deficiency. Anxiety is usually from constant hot flashes, the surges of FSH and LH, anxiety attacks. Those I see a lot with men when I'm treating men, and they don't get hot. They get anxious. It goes away in a minute, but they're miserable because they're in a meeting and it's driving them crazy, but women do the same thing. But they're waiting for the hot flash, but they get the anxiety instead. Parkinson's disease is one that we hardly ever talk about with testosterone, but testosterone stimulates dopamine. So it decreases the rate of disintegration, if you will, Parkinson's disease. And improving your immune system always protects you from cancer. So physiology, this is really, really basic. So don't, this is my little graph. Ovaries make the majority of testosterone when we're in our fertile stage before we hit menopause. Actually, after menopause, no, we don't have much at all anyway. But testosterone has an effect on the adrenal. When testosterone drops, the adrenal makes more estrone. Estrone is the hormone of belly fat, breast tenderness, breast cancer. Estrone's the bad guy. It makes us all, both men and women, have the apple shape, and it really does decrease your memory. It affects how you think. So estrone then goes and it actually stimulates belly fat. So belly fat then stimulates weight gain, which makes more estrone, because fat makes more estrone. So it's one of those very few positive feedback systems in the body that it just keeps positive, positive, positive. It's impossible to stop this process unless you block it or you give testosterone. If you give testosterone, then testosterone will start the process the other direction. It will decrease the production from the adrenal, or you could use Arimidex, which also decreases testosterone's conversion into estrone. So those are the two methods, but giving testosterone is the easiest. It's kind of a one treatment, and it fixes everything else. This is what I kind of draw in my office on my piece of paper where I'm drawing for everybody. This is what happens when your testosterone drops, your estrone goes up. So they have a picture in their mind so they know what's happening when they go home and they don't get confused. So this is the effect of estrone on women. And migraine headaches are in there too, and that's one of the things we do the best with testosterone. We have neurologists that send me migraineurs that are in the right age bracket, anything over 30, 38, or people who have had their ovaries removed earlier or at any time. They send to me, and we have a really good record of treating this. Unless they have a different trigger, sometimes there's a few triggers, but we take care of the hormonal trigger by giving them testosterone. It actually modulates the neurotransmitters and stops the vascular dilation in the brain. E1 really has very few redeeming qualities, except it can make a little bone, but other things can too. There's a three-way relationship that not many people talk about between estrone, estradiol, and testosterone. But when we first look at lab, you should look at the estradiol and estrone ratio. When we're young, we have a 2-to-1 ratio, estradiol to estrone. As we lose testosterone, our estradiol goes down, our estrone goes up. That's one of the ways I make sure that when I see a low testosterone, I look at this ratio and confirm that, yes, the patient has the effects of low testosterone because their estrone is higher than their estradiol. So this is one of those things that can be balanced with testosterone, but it also can be imbalanced by taking other hormones that are like oral ERT that are synthetic, or the patch, or the synthetic gel. All of those were synthetic except the bioidentical vag tabs. But at the very top, you see that a youthful ovary makes 2-to-1 estradiol, young to old. And at the very bottom, bioidentical pellets is the only one that can recreate the 2-to-1 ratio. Everything else in between is not as good, which is one of the reasons I only do pellets now, because I find estrone to be a huge problem. So pellets take care of that. Yin and yang of testosterone. So this is the difference between men and women, but I just put the women's slides in here, or I'm going to go over. But men have 10 times as much testosterone as women, but that doesn't mean we don't need it. I mean, it's just that they have more. Female age of testosterone deficiency is 45. Average age for men is 55. Yet I'm starting to see younger and younger men in the office, which is really scary. They're 40, and they've got a testosterone of a 70-year-old. So what's doing that? I have no idea. They didn't have head injuries. I go through the whole thing. There's nothing that happened to them, and they're really low. They may not tell me about any anabolic steroids they used in the past, however, because they're afraid to tell about that. So they're not fertile in general, and they're done with childbearing, or child making. So we're okay with giving them their testosterone back. Testosterone, the gender difference, age of testosterone deficiency is different by 10 years. One of the reasons why there's so much trouble in marriages, because men are fine, and then their wives may be a few years younger, but they hit testosterone deficiency sooner, and they don't want to have sex anymore. And the men say, oh, you changed the deal. So that's one of the reasons I believe that we see all the divorces in the 40s, when women are in their 40s, because that's when the deal changes. They don't want to have sex anymore, and their husbands go, wait a second, this isn't what I signed up for. If we did it at the same time, we probably wouldn't notice. Testosterone blood levels, 10 times higher in men than women, and free testosterone levels are about the same, 10 times higher in men than women. So if you look at women's total testosterone in the blood of a young, healthy woman, which is what you need to compare them to, not the numbers on the lab test, you should have 30 to 75. That's what women between 20 and 40 have. We compare women's bones to a 29-year-old female. When we do the bone density test, we should be doing that with all of our lab tests. So this is comparing women that you see that are older to a young, healthy woman. And so this is the normal total testosterone, but really the money's where the free testosterone is. And I look at 7 to 10 nanograms. It depends on the lab. And free testosterone is very hard to measure, very hard to measure. So usually I find that treating people who are less than 7 to 10 it will be very effective, and they'll feel better. Total T is not the test to judge adequate replacement after you've given it to them, because total T is a number that is a lot higher in women to get them the necessary free T. We have a lot of sex hormone binding globulin. We have a lot of other hormones and a lot of steroids like cortisol. We have a lot of stress. That helps bind up our testosterone. So I look at just free T. I don't even order the total T because the mainstream internal medicine guys freak if they see a woman with a testosterone of 200. And it doesn't mean anything because their free testosterone is probably 10. So it's not a lot, but they don't know what that means. So they just freak over the total testosterone. It's not doing anything to them. It's totally inert. So free testosterone mirrors the symptoms that women have. So that's why we should follow it. It also crosses the blood-brain barrier, which is why it's very important for us to look at that particular hormone. And it shows the balance between sex hormone binding globulin and testosterone. Factors that lower free T levels are estrogen replacement, estrogen dominance, even if no one's taking estrogen. If you take their estrogen or estradiol level and it's 400, then they are stimulating their sex hormone binding globulin, and they're lowering the free T level. Alcohol intake, cortisol stress, even elevated albumin. The diagnosis and treatment of testosterone deficiency. The risks are the biggest issues, and the risks aren't big. Facial hair. Okay, you can have it taken off. You can use spironolactone. I'll go over the treatments or the prevention in a second. But thinning hair at the temples, that's a little bit more difficult to deal with. And return to body hair, like on your arms, legs. If you had a belly body hair and you're female, then you'll get it back. Basically, whatever you had when you were 30 comes back. And that's not always happy for most women because they thought they were done with it. But a lot of good things happen too. Temporary risks, clitoral enlargement, it comes and goes. Usually, I don't understand the big hubbub about that because no men ever have complained to me about their penis getting larger with testosterone. I just don't get it, why everybody's excited about this. In medicine, obviously, if you're not taking anything and you have a large clitoris, it might mean that you had a tumor of the ovary, which I've never seen in all the years that I practiced gynecology. So I don't know why anybody's excited about that. It goes away after the body gets used to the treatment. And so I don't find that to be an issue for any of my patients. Now, a lower voice in singers is an issue. And anybody who's had a damage or radiation to their vocal cords, lowering their voice or making it less easy to hear if they've had radiation or some other kind of surgery to their vocal cords might be a problem. In that way, you either have to use finasteride to block the DHT, which is the active ingredient that's causing that, or you have to lower the dose so that they don't, or in singers, you have to maybe not give them testosterone, just give them estradiol. It depends on what they agree to when they know the risks, because it is their choice. And then excessive libido in older patients, sometimes that's a huge problem. So women who don't have a partner or don't know how to use a toy or a vibrator, I have long talks with them, and that I don't get very far. They're very uncomfortable with it. So oftentimes I'll just lower the testosterone dose. Then they come back and say, well, hey, I don't feel as good as I did before. So I tell them they have to make the choice. So it's either you have to order something from drugstore.com in a little brown box that comes in the mail and put some batteries in it, or you're not going to feel as good, because there's a trade-off, and they have to be able to be the ones that make it. So, and I think the biggest problem with testosterone in women is women have to either be menopausal or they have to have permanent birth control. And birth control pills don't work because they negate the effects of the testosterone that we're trying to get. So it stimulates the sex hormone binding globulin so much that we can't get a good resolution of symptoms. Condoms aren't adequate. You just can't have a baby. It's category X. It's going to make a girl baby look like a boy baby. That's just not going to happen. So they have to sign their consent. On that consent has to say, I am using permanent birth control or something, or I'm menopausal. Otherwise, they don't get their pellets. So choosing a delivery system, getting short on time. I use subcutaneous pellets, but a lot of people use other types of creams, gels, buccal tablets. Depends on your pharmacy and how good they are. And most patients may want to choose. I mean, I just like to use the pellets because it's very low risk in terms of phone calls, and it's low risk in terms of dangers of them imagining they've got something. I know what they're getting. I'm putting it in. I don't have to think maybe they put on 10 times as much, or maybe they took 10 times as much, so I'm in control of that. So yeah, maybe I have a control issue. But it makes it easier to answer phone calls when you know exactly what hormone they got when and how long it's supposed to last and what their last blood test was. And I think that the lab tests are much more relevant when you're doing pellets. Sometimes I do lab tests on vag tabs and they're like 1,000. The patient still doesn't feel well and her symptoms aren't better. So I don't even know how to evaluate that. So for me, and I'm just saying for me, you guys have your own opinions on this, this is why I do pellets. It's much easier to manage for me, and it seems to have a much better outcome for the patient. They feel really much better, and within 4 weeks. These are the cost issues. You can look at this a little bit later, but it turns out that if your patient has to pay for any bioidentical hormone, then they have to look at the cost issues. Usually oral will be paid for by insurance, but they've taken Estratest. At least we can't get it, so I think it's off the market. I didn't look that up for the recent availability of it, but that's the cheapest, but methyl testosterone is really bad for you, and it causes a lot of anger and liver tumors, so I wouldn't suggest that. But all the other bioidentical hormones end up being about $100 a month, unless you're in a really good area or have a really inexpensive pharmacy. And pellets end up being $125 to $175 a month if you pay per month. So it's not that outrageous, and they usually get off some of their other medications if they're on the pellets. So it usually is about a wash, and they feel really good. Goals for dosage, relief of symptoms, and no voice change. Basically, blood levels of T-free is higher than physiologic. So that's partially because we lose androgen receptors as we get older, and we have to flood them. So that's what I found, is that usually you have to have a higher free T to get the outcome, but we don't have any downside to that. Each patient has a different ideal level of T, so that's one of the things that you have to mark on the chart. This is ideal, this is where we want to be, this is where she feels good, and have that on their chart so you look for it and you remember it. This is me putting a pellet in, that's an estradiol pellet into a trocar. My pellet dosage and frequency is for women 125 to 300, depending on a lot of things. But that's complicated, and that would take way too much time for this lecture. We redose every 3 to 6 months, and that seems to be adequate. Usually the 6 months is in older patients or sedentary patients, and the 3 months are in those I call them hummingbirds. They're always moving. They never sleep. They run marathons. Those are people that have to have this more often. So blood lab goals for testosterone pellets, we do a first morning draw. We don't draw the total testosterone. We just draw the free. And we're looking for, after the pellets, we're looking for 15 to 40 nanograms per deciliter. That's what we're looking for. And usually in that range, people feel awesome. We want the DHT to be less than 20, that's Quest's normals, and estradiol to be less than half of the, estrone to be less than half of the estradiol. LH less than 10, just because we want to make sure testosterone does affect the LH. So both LH and estradiol, testosterone and estradiol affect LH. So we want to have it less than 10 so they don't have night sweats or hot flashes. Troubleshooting, this is what you were looking for. Unwanted facial hair. Spironolactone, ideal dose is 100 milligrams a day. They shouldn't be on any other diuretic, so you're either going to have to change them from their diuretic with the approval of their internist or their family practice doctor, or if you're the family practice doctor, you've got to change them. But 100 milligrams is ideal for preventing hair growth. And usually I start people who have had hair growth when they were younger on spironolactone when we start the pellets so that we can prevent it. If it's really difficult to manage, we use finasteride, but we only use half of a 5 milligram tablet. And I use 5 milligrams because the women's dose is 1 milligram and it's 3 times as expensive, and there's no generic. So I use the men's Proscar dose, and I have them cut it in half and decrease it to once a week. Some people take it half once a day, but I don't have very many people like that. So that's to keep the DHT in the hair follicle in check. And then weight gain, we try to control estrone. So testosterone does part of it. DIM, extra strength, does part of it. And in some cases, we have to use Arimidex in the pellet or orally. But, the side effect of Arimidex is arthritic symptoms, and we're trying to get rid of those. So we don't want patients to have arthritic symptoms. So I usually try the pellet first, see if I can get their weight down, their belly fat down. This is one thing that I just want to mention, and we're right at the end. Genetic aromatization defect. These are people who are usually Southern European, but of course I find them everywhere because Rome went everywhere, and there were a lot of invasions. But when there are a lot of people that at a certain point, both men and women, they start converting their testosterone in a big way into estrone, and it's genetic. So what you see with a pellet or with estrogen testosterone, replacement is give them their testosterone for the first 2 to 3 weeks. They start feeling great. It's awesome. And then all of a sudden, their breasts don't fit into their clothes, and their belly fat increases, and they gain weight. And so there's no test that I can do that's actually reasonable to find out if they have this problem, but that's the sign. The sign is all of a sudden, instead of feeling really good, they feel really bad, and they start out feeling really good. And then I usually ask them about their family tree, but I do that ahead of time. I don't always get it right, but it doesn't always follow family trees. However, treating with DIM initially, estradiol orally until the next pellet dose is very, very treatable, very curable. And then with the next pellet dose, we use Arimidex and testosterone in the pellet. So then they don't have to deal with another medication. So the excessive aromatization of T to estrone, you can read this, causes more migraines. So oftentimes this is a big deal. They came to me for migraines. They quit. Then they start up with a vengeance. So this is something that I have to keep my eye out for, and so should you. They found this in a study that was done on men in Sicily because they found that men in Sicily had the highest rate of male breast cancer. That's where they found the aromatase enzyme, and and from that came Arimidex and all the other aromatase inhibitors. But that's how they found it. So the highest rate of breast cancer and aromatase defect is in Sicily. I'm half Sicilian, so I got to enjoy this deal on my first dose. I felt great for 4 weeks, and then, whoa, I couldn't fit any of my clothes. So this is the treatment. Troubleshooting the excessive sex drive we talked about. It usually equilibrates in about 2 weeks. And then the clitoral enlargement, I forgot to talk about the estrogen. You can apply estrogen cream to the clitoris, and that tends to calm it down. But once again, I don't think it's a problem. It usually goes away or goes back to normal on its own. So the logic for patients not taking testosterone is not logical because they say, I don't want to put anything in my body. Okay, well, you use aspirin, you get a flu shot, everything you do nowadays is something in your body, plus they're drinking soda with, out of a plastic cup. That's not a logical argument. So some people aren't going to listen, but I just say, it's going to improve your health. It's going to make you feel better, and your husband will be a lot happier, and you'll be a lot happier. So that's kind of how I explain it at my office, and sometimes I get through and sometimes I don't. We have had all of our testosterone products prevented from passing through the FDA because of things like facial hair growth. Nobody died. It was not a medical, life-threatening problem. It's ridiculous. It's made everybody afraid of testosterone, mostly women. And these are the things that are keeping us from medical equality. Testosterone's not just for men. This is my benediction. I can hear the choir. It's not just for men. We must get FDA approval for some testosterone for us to get payment for our bioidentical testosterone. We have to change the societal beliefs about women over 40. We're not all crazy. We're not all hot flashing and non-productive. We're not all fat. We actually are productive human beings in society, and they need to treat us like that. And that's something that only we can do in this room by having discussions with our patients. And women also must get over their fear of everything that shows up in the newspaper. And I know you all deal with that every day. People bringing in articles. Look at this. It's scary. This is scary. And we've heard this weekend or this conference all about headlines that are wrong. And all of the information is wrong, but it's still a headline in JAMA. So we have to counteract that, or we're not going to get anywhere. So that's why I wanted to make this. I wanted to talk, and I wanted to talk here because I know everyone here deals with treatments that are on the cutting edge, that are creative human beings who are trying to make their patients better. And I just hope that you can join with your patients in trying to get the rest of the world to see the beauty of actually giving women the same treatment as you all guys get. Thank you very much. I appreciate your attention.
Email your questions or comments to podcast@biobalancehealth.com. You can find the BioBalance Healthcast on iTunes and on YouTube. For more information about bioidentical hormone pellet therapy and other reverse aging solutions, visit biobalancehealth.com or call 314-993-0963. You can find Dr. Maupin on Twitter @Dr. Kathy Maupin and on Facebook at facebook.com/biobalancehealth.